Millions of Americans are impacted by upper GI reflux conditions, such as GERD.
Gastroesophageal Reflux Disease, or GERD, affects about 1 in 5 people in the United States, and that's over 60 million individuals.
And LPR.
Estimates suggest it may affect around 10% of the population, with some reports actually suggesting over 80 million individuals have LPR in the US.
And later, learn how a reflux disorder can impact an individual's quality of life.
Feels like a physical and social prison because I feel often cut off from people, a bit like being in a prison.
Discover the lowdown on upper GI reflux conditions inside this edition of CTSI Discovery Radio. Welcome to CTSI Discovery Radio. I'm your host, Brian Belmer. CTSI Discovery Radio is brought to you by the Clinical and Translational Science Institute of Southeast Wisconsin. The CTSI is a consortium of researchers, doctors, scientists, and others representing 8 institutions, including the Medical College of Wisconsin, Milwaukee School of Engineering, Marquette University, the University of Wisconsin-Milwaukee, Children's Wisconsin, Froedtert Hospital, Versity Blood Center of Wisconsin, and the Zablocki VA Medical Center. The CTSI works collaboratively across all of our member institutions. Our mission is advancing health through research and discovery. Acidic and non-acidic reflux disorders of the upper gastrointestinal, or GI tract, cause discomfort and even damage for millions of Americans. But what are some of the common reflux conditions to be aware of? We found out by asking an expert. Dr. Nikki Johnston is a professor, Department of Otolaryngology and Communication Sciences, and Microbiology and Immunology, and heads the Pepsin and Reflux Lab at the Medical College of Wisconsin. Our conversation begins with Dr. Johnston sharing exactly how common reflux conditions like laryngopharyngeal reflux, commonly referred to as LPR, and gastroesophageal reflux disease, also known as GERD, can be.
Reflux conditions are very common. Gastroesophageal reflux disease, or GERD, affects about 1 in 5 people in the United States, and that's over 60 million individuals.
As for laryngopharyngeal reflux, or LPR,
it's a bit harder to pin down, but estimates suggest it may affect around 10% of the population, with some reports actually suggesting over 80 million individuals have LPR in the US.
How does Dr. Johnston characterize the seriousness of LPR and GERD for patients diagnosed with them?
Both conditions can have a significant impact on quality of life. GERD can lead to esophageal damage, ulcers, and in some cases even cancer if left untreated. LPR, while often called silent reflux, it can be just as serious. It affects the throat, the voice box, and sometimes even the lungs. People may struggle to speak and to eat comfortably, so it's not just discomfort, it's really life destruction.
Next, Dr. Johnston shares her insights on what's happening physiologically when someone's suffering from LPR.
LPR is when the stomach contents, including digestive enzymes, particularly pepsin, travel up from the stomach into the throat and the voice box. Unlike GERD, this doesn't always involve acid. And since the tissues in the larynx are much more delicate than those in the stomach and the esophagus, they're easily damaged by even small amounts of reflux.
What causes someone to develop LPR? Is it hereditary or perhaps brought on by environmental means?
There's no single cause. It can be anatomical, so for example, a weak upper esophageal sphincter, or related to lifestyle, diet, or yes, even genetics.
What are common symptoms of LPR? Dr. Johnston tells us there are several.
Chronic throat clearing, cough, hoarseness, postnasal drip, globus, which is a sensation of persistent lump in the throat, And these are often without heartburn, so I think that's why it frequently gets overlooked.
But its impact on a person's day-to-day function and quality of life can be, well, actually
Huge. People may lose their voice and or have significant pain when they speak and therefore struggle in social settings and professional settings. Many feel dismissed or misdiagnosed, which can be incredibly isolating.
Then, in looking at Gastroesophageal Reflux Disease, or GERD,
GERD is caused when the lower esophageal sphincter doesn't close properly, allowing those stomach contents, so the acid and pepsin, to flow back into the esophagus. And that acid and pepsin causes inflammation, irritation, and damage to the esophageal lining.
in terms of what causes GERD,
It's a combination of anatomical, environmental, and sometimes genetic factors. Diet, obesity, smoking, and even stress plays a role.
what are some common symptoms of GERD?
Typically heartburn, chest discomfort, regurgitation, and sometimes difficulty swallowing.
And just like LPR, GERD can also significantly impact a person's quality of life.
The impact ranges from mild to severe discomfort. GERD can result in sleep disruption, dietary restrictions, and significant long-term health risks if it's left untreated.
Of these two reflux conditions, is one more debilitating than the other, or are they equally serious?
So they're both serious in different ways. GERD has more visible, measurable symptoms and is often easier to diagnose. LPR is a bit more elusive, and since it lacks heartburn, many patients are misdiagnosed with either allergies, asthma, or even anxiety. And we hear this over and over. Patients will say, I saw 5 doctors and still didn't get any answers. And so that's what drives my research.
We'll learn about Dr. Johnston's most recent research success in a moment. First, we asked her if either LPR or GERD is particularly challenging to diagnose, or are they rather self-evident by their symptoms?
Usually by their symptoms. There is technology that can be used to diagnose reflux, to measure reflux events, how many events a person is experiencing, the duration of those events, and therefore, of course, if a person is experiencing more than normal reflux events, it would indicate the condition may result in disease.
Historically, treatments for LPR and GERD focused on proton pump inhibitors, medications to reduce stomach acid. Were these particularly effective treatments?
Proton pump inhibitors, or PPIs, are widely used to reduce stomach acid. They don't stop reflux from occurring, but instead reduce acid production in your stomach, making that refluxate less acidic. They work well for GERD in many, but not all cases, helping to prevent that acid from damaging the esophagus.
But for LPR, different story.
For LPR, where acid is not the main problem, they're often ineffective, and it's a frustrating reality for many patients with LPR currently without a medical treatment.
Although she aims to change that. Through groundbreaking research by her lab, Dr. Johnston and her team have identified a major culprit in reflux disease. It's the digestive enzyme found in our stomach that she mentioned earlier, pepsin.
Diagnosis and treatment of reflux has historically been focused on acid, but with the introduction of new technology, it's now known that non-acid reflux is a serious problem. So work by our group and others have shown that pepsin is likely responsible for those persistent symptoms and endoscopic findings despite PPI acid suppression therapy, so is a key therapeutic target.
When acting properly in our body, what is pepsin's role as an essential enzyme?
Pepsin is the primary digestive enzyme which is made in your stomach. It's essential for breaking down proteins when food is present, but when that pepsin escapes from the stomach and reaches the throat or the airway, as in LPR, it becomes harmful digesting those normal tissues. Embeds in the tissue where it becomes reactivated and can cause inflammation, damage, and contribute to the development of disease.
And identifying pepsin as a key contributor to LPR is a game changer.
Pepsin will cause laryngeal damage even in non-acid reflux, so irrespective of those acid-suppressing PPIs. So this really was a game changer because it explains why acid suppression therapy doesn't always work. You can remove the acid, but the pepsin is still there doing harm.
So their research provides some answers as to
why the current medical therapy is not effective, because new technology was able to show that many patients have symptoms associated with non-acid reflux. This research helps explain why that is happening and gives us a target to develop a new therapeutic to help those patients.
which is why Dr. Johnston and her lab are
developing a pepsin inhibitor as a safe, effective, and efficient treatment for reflux disease to address this significant unmet clinical need.
Fortunately, they haven't needed to develop their groundbreaking drug from the ground up.
We discovered that a drug called fosamprenavir, originally developed to treat HIV, has the ability to bind to pepsin and neutralize it. So this was a huge breakthrough. We found that fosamprenavir prevents pepsin-mediated laryngeal and esophageal inflammation and damage in preclinical studies. And in support, patients taking this drug for HIV have a significantly lower incidence of LPR compared to that in their general population.
She explains that repurposing fosamprenavir, an existing drug,
saves significant time and cost. Fosamprenavir is an ideal drug to repurpose because it targets a foreign virus, which is otherwise not present in most individuals, but most importantly, already has a good safety and tolerability profile, allowing safe assessment in a phase 2 clinical trial.
To be clear, they have slightly modified the drug for use as a treatment for reflux.
We've engaged LGM Pharma to create a new sustained release formulation of oral fosamprenavir, but in addition to our oral formulation, we're also reformulating fosamprenavir into an inhaled therapy for local treatment by dry powder inhaler, allowing a higher concentration at the disease site and lower systemic concentration. So yes, we have two different formulations under development, one for GERD and one for LPR, but both the active ingredient is fosamprenavir.
Also, it's important to note that being an existing drug, though modified, allows it to go directly into a phase 2 clinical trial.
Repurposing it and reformulating it saves significant time and cost. And because we already know that fosamprenavir has already been used in patients for many years, and the safety of the drug is well documented, that allows us to move straight into a phase 2 clinical trial, which is very exciting.
To develop the newly reformulated drug, Dr. Johnston tapped into her entrepreneurial spirit to launch Enzyme Biomedical.
I co-founded Enzyme Biomedical with my business partner, Franklin Vigili. We have a strong, cohesive team of expert strategic advisors which represent the clinical, business, pharma, and drug development perspectives. It has been a leap from academia to entrepreneurship, but a very exciting and fulfilling opportunity. And the goal has always been the same, to get an effective treatment for patients.
Exactly how effective, they hope to find out, as they'll soon begin their phase 2 clinical trial.
Our first trial will begin this October. We're shooting for October 15th. We open enrollment for a 12-week randomized, double-blind, placebo-controlled phase 2 trial to assess the efficacy of our oral formulation for LPR. We need 104 people, and we currently have over 400 volunteers, so we expect to be able to complete it expeditiously.
In addition, a second clinical trial is planned for reflux patients with
PPI refractory GERD. While the majority of patients with LPR do not respond to PPIs, 40% of GERD patients also have persistent symptoms, and so we hope to start that GERD trial early next year.
Alongside the research work of Dr. Johnston's lab and Enzyme Biomedical, support from MCW has also been instrumental.
The Medical College of Wisconsin has been extremely supportive of this drug development program. I'm personally very grateful that MCW supports entrepreneurship. And I think investment in the health sector, including startup companies, will be a significant catalyst for regional growth and provide an opportunity for us to become a national leader in healthcare advancements.
She also acknowledges
MCW's Office of Technology Development, Therapeutic Accelerator Program, Office of Research, and of course our CTSI that provides invaluable infrastructure for research and clinical trials. I think MCW's commitment to build a strong entrepreneurial ecosystem is an asset for our researchers, but also for our industry looking for academic industry partnerships.
if you want to learn more about LPR or GERD,
American Academy of Otolaryngology, or the American Gastroenterology Association website, our MCW Reflux Research website, We're also sharing updates at enzymebio.com, and always talk to your trusted ENT or GI specialist.
To sum it up,
reflux isn't just about acid and heartburn, and I think for many this has been overlooked for far too long, but there's hope and there's new treatments on the horizon.
and if you are impacted by a reflux condition, you're encouraged
Not to give up, you're not alone. We are working every day to bring an effective treatment to people like you, and we're very optimistic that this drug will help millions of people with reflux disease that don't respond to the current medications.
By now, you may be wondering, what's it like having a reflux condition such as LPR? How debilitating and challenging can it be, especially for someone who uses their voice significantly in their profession? We're about to hear from one man who's living this exact experience. For this, we take you across the Atlantic to England, where we meet him now.
My name is Sam Winston. I am a singer-songwriter and musician and a music teacher from South East London.
Sam shares a bit more about his life situation and interests.
I am an only child and pretty close to my family. I have quite an extended family as well. Really close to a group of friends. I love cooking. I did love sport, and I still do, but I had some musculoskeletal injuries. I love nature, reading, learning and expanding my mind, that kind of thing.
All of which contributes to his active lifestyle and inspires his music as a professional singer-songwriter.
I've been playing music for as long as I can remember, and I was trying to be in bands, but I felt the pull to be more a solo artist because I think I was putting in more effort than the other band members, writing all these songs. So I worked feverishly hard on an album that I'm really proud of, that's on Spotify, it's on iTunes. And that was the period when I was gigging much, promoting the album, living my best life, really.
And who could blame him? After all, he was opening for artists such as Boy George and drawing praise from no less than legendary songwriter Chris Difford of the band Squeeze. Aside from his musical success, how does Sam describe his overall health at that particular time?
Until I'd done more self-introspection, I would say really good health, and it was, but the more I've looked into it from a kind of objective point of view, I definitely think there's an underlying anxiety, and I didn't even realize that I was kind of going through that. So physically, good. Mentally, definitely some stress and tension, but overall, not too bad at all, and no major things going on.
So as his musical career was taking off, Sam says his lifestyle was
pretty active and pretty healthy. I have a pretty good diet. Don't drink anymore. I don't smoke. Don't do drugs. For all intents and purposes, pretty healthy and above average, I would say, in terms of what I put into my body and that kind of thing.
Generally speaking, Sam was living the good life.
I was gigging a fair amount, had lots of shows and gigs planned in the diary, was also teaching a fair bit, and generally just feeling good about where I was and what I was doing. And I suppose I was not in a bad place, I was in a decent place.
That is, until 2018, when suddenly Sam's health and life began to change.
I would suffer from really weird sore throats, like not usual, and it would look quite red and inflamed. And I would say to people, this is really weird. It feels like I'm breathing out like a battery, like fumes. And I'd never actually heard of acid reflux. So I just said to someone randomly, it feels like I'm breathing out fumes, and there's a lot of throat clearing, a lot of tightness and discomfort.
He did what anyone would do.
So I went to the doctors, and they said, oh, it's probably nothing, just take ibuprofen. And then eventually I went a couple of times, and they gave me some antibiotics because they thought it could be a bacterial throat infection. So that was really the start of it, breathing out the fumes and just feeling something wasn't right. A lot of inflammation and pain, swallowing, that kind of thing.
Sam tells us he remembers
it happened gradually, but kind of perniciously. It just kind of crept up on me. I mean, if I'd have known what it would turn into now, I would have been in full-blown panic mode. But at the time, I just thought, oh, how annoying. I've got these gigs coming up. It's going to be painful. I'm going to hopefully just take some antibiotics and that'll be that. It will work itself out in a number of weeks, months tops, that kind of thing.
And he did something else many of us would do. Turn to Dr. Google.
It was maybe a month on and off feeling that something wasn't right, almost like a fuzzy feeling on my tongue and throat area. I would go to Google and say, why isn't my viral throat infection getting better? Search what could make your throat feel bad. And it was just coming up with viral throat infection. But on Google, I didn't stumble upon LPR at all. So yeah, it was a lot of Googling home remedies and maintenance, really.
With no solid answers about his condition, frustration began to set in.
I do feel a lot of empathy and sympathy for the doctors. I mean, they're so busy in this country. I don't know what it's like in America, but they are so busy. And so I do have a lot of respect for doctors, but I just think they can flip the net. So I think that's what was happening for me, especially early on.
But after persistently advocating for himself with doctors, some progress.
It was only until I saw one doctor who I said, look, I think something needs to be done. Can you send me for some tests? He said, yeah, sure, okay. I don't think it's anything other than what we've already said, but you never know. So I kind of had to push it a little bit. I had to kind of stay on top of it.
Finally, after months of doctor appointments and disappointments, a breakthrough.
After the initial symptoms, there was probably a month where I tried to sort it out myself. Then another month or two going back and forth to the doctors, taking these antibiotics, which kind of did help for a bit, and then it would come screaming back. So I would say that was about 4 months to that point. But then, of course, I had to be on a waiting list to see the special ear, nose and throat doctors at a fairly big hospital. So until I actually got that appointment, that was probably about 9 months when I actually heard LPR for the first time.
Once diagnosed with LPR, what was Sam told about his condition and possible root cause?
As to the root cause, there's so many and there's so many varying factors. As for my root cause, they said it could be stress, it could be dietary. They said cut out dairy, try cutting out spicy foods, raise the head of your bed. So yeah, they didn't really know, and they were coming up with decent hypothesis. It was a bit closer. It felt like I had some answers, but also they were quite generalized. They were not too specific.
How did he react to receiving his diagnosis?
I'm quite a proactive person, Brian, so I just felt, right, I'm going to get on top of it 100%, so hopefully in 2-3 months it'll be better. The doctor said it will probably take 3, 4, 5 months for you to start seeing any difference because it takes time for the things in the stomach to calm down the things in the throat. I felt quietly confident. Yeah, I felt quietly confident, I would say.
And that quiet confidence allowed him to face and share his LPR diagnosis.
Even early on, I was talking to my parents and talking to my close friends, saying I'm losing my voice and I had to cancel gigs. So people knew. I think I even did a Facebook post about it, asking people, has anyone got any experience with a sore throat that comes out of nowhere? So I did tell people, yes.
But behind that quiet confidence, there was still concern, especially considering his professional career.
It was really tough, and as well as singing, I'm a teacher as well, and at the time I was teaching a lot of classes to adults with learning disabilities, and before I'd be shouting in a joyful way at the top of my lungs, not really needing a microphone. I was just fully invested in my work, in my teaching, in my singing, not even thinking about any discomfort.
However, things were different because
before this, I could sing 2-3 hours and not even have a hiccup or a bump. It might be after a 2-hour gig, I might be a bit tired, but I would feel fine.
And despite the peace of mind from knowing what the condition was he was experiencing, still,
this was like razor blades in my throat. It felt like every time I swallowed, it would hurt. Fumes kept coming up a little bit. My tongue was a bit swollen.
Which meant changes needed to be made.
Something that I still do, like with teaching, I'll use a microphone, which is okay, not ideal, especially if you have to move around. So yeah, there were some big changes going on.
Along with these initial changes to his day-to-day life, his overall outlook on life also changed.
I was just annoyed that I'd had to cancel these gigs because, you know, I'd been working so hard on this first album. It was now out. I had people interested in it. So I was just a bit unsure of the future. A lot of uncertainty and anxiety, I suppose.
Fast forward to today, when Sam has now adjusted to living life with LPR.
I've tried everything under the sun, Brian. There's some things that work, there's some things that don't work, and there's a lot in between. But I would not wish this on my worst enemy, especially if you're a performer or anything like that.
So what is he doing to manage the symptoms of his LPR?
I'm gargling with warm, salty water to hopefully draw some of that inflammation out. Gaviscon Advance before bed and sometimes after meals. And I've tried so many herbal supplements, oil of oregano, deglycerized licorice. I've tried so much, Brian, over the years, and it's so random.
Although Sam might benefit from Dr. Johnston's clinical trial, he's unable to participate.
I have spoken to Dr. Johnston many, many times, but I'm not sure I would be eligible from a scientific perspective, so it's not going to happen for me just yet.
But he's excited about the trial.
I am very, very hopeful. I'm seeing that as a lifeline because I know her research has indicated that fosamaprevir can really turn the tide on LPR and in some cases reverse it. When I heard that, I thought, wow, this could be the actual golden ticket.
In the meantime, Sam presses on because, well, he's resilient.
Even though I can have some anxiety, I think it comes with the singer-songwriter territory, but I'm quite a resilient person. I will get sad for hours, and then I'll have faith that maybe next week won't be so bad, maybe. So I'm kind of relying on maybes.
Speaking of maybes, maybe there's a philosophical way to look at his LPR. Sam thinks so.
I would say there are some blessings in disguise. I've done a lot of introspection that probably wouldn't have happened if I hadn't had the LPR. So what I'm trying to say for the benefit of your listeners is it might not, but it might be an indicator that there are other things, mental, physical, emotional, spiritual, going on. And it might just help spark them off on an inward journey.
It certainly has for him, and that will restore Sam's quiet confidence to his fully confident singing voice, highlighted on his next album. Until then, check out Sam and his music at samwinstonmusic.com. Sam wants to escape a life that
feels like a physical and social prison because I feel often cut off from people, a bit like being in a prison.
And enjoy a life filled with
hope, faith, belief. It could be quite miraculous. That's what I am clinging to.
Want to say I've damaged goods, overlooked, misunderstood.
And on that note, we're all out of time for this edition of CTSI Discovery Radio. As always, thanks to each of our guests, Dr. Nikki Johnston, and special thanks to Sam Winston for sharing and singing on today's show. I hope you've discovered something by listening to today's show, and I'm doubly hopeful you'll join us again next time. CTSI Discovery Radio airs the third Friday of every month. Make an appointment on your calendar and join us for each episode. On behalf of the Clinical and Translational Science Institute of Southeast Wisconsin and all of our affiliate partners and members, I'm Brian Belmer, wishing you happier, healthier days ahead. For more information about research or to listen to the podcast of this or any of our shows on demand, please visit our website at ctsi.mcw.edu. CTSI Discovery Radio is written, produced, and hosted by Brian Belmer in collaboration with WMSE Radio. The CTSI and this program are under the interim direction of Dr. Julie Freed.